I mean, I'd just like to start off by thanking Nev and Tony for inviting me to speak with the group this morning. My name is Katie, and I am a laboratory-based cancer researcher at the Peter MacCallum Cancer Centre, sort of working primarily on metastatic prostate cancer, which I'll be talking about today. Along with some of the challenges of predicting and treating cancers that have spread to other parts of the body. I'll admit that I don't usually give many talks that don't involve a lot of sort of dense scientific language. So if you have any questions or would like some more information or clarification on anything that I'm talking about, please feel free to stop me and we can have a discussion about it. We've got plenty of time and this is informal. And so don't feel like you have to wait until the end. So I just thought I'd start by telling you a little bit about myself, which has been briefly touched on. So my actual title is postdoctoral researcher, which basically just means that I'm a research scientist with a PhD. I've been working on metastatic prostate cancer since 2016, and I've been at Peter Mac since 2019. And my work sort of mainly involves identifying and testing biomarkers, which are basically just physical flags or beacons on or within cancer cells that can be used to predict cancer progression if their levels go up or down, or they can be used to direct drugs or therapies to in order to kill cancer cells. I also investigate how we can use information provided by different kinds of cells, including immune cells at the tumor site or in blood samples, to improve treatment strategies and sort of future options for men living with an advanced stage of disease. Now, much of the work that I do now is focused on new radiation-based therapies and how these therapies can be used differently or perhaps more effectively to fight cancer long term. A large part of this actually requires generating a good immune response, much like when you develop immunity to viruses or infections. But I guess the primary goal of my work really is to better understand why prostate cancer that has spread to places like bone is so difficult to treat. And this is what's really critical to improving not only survival, but quality of life for men with metastatic disease. Now, I know you probably don't need much convincing, but surprisingly, despite the perceived importance of prostate cancer research, this is still a really underfunded area of medical science. And one of the reasons for this is that in Australia and around other parts of the world, localized prostate cancer, when it's caught early enough, has a really good prognosis. And this accounts for around 80% of cases. The other promising news is that while we've sort of seen this increase in prostate cancer detection over the past 20 years, which is mainly the result of improved screening by doctors, PSA monitoring, which I'm sure many of you have all had experience with, and better imaging that can pick up even very small lesions. We've also seen a general downward trend or decrease in mortality in westernized countries. And this has been linked to earlier detection and early intervention with things like surgery or treatment with hormone blocking drugs. But unfortunately, up to 30% of men who receive these sort of early or first line therapies will develop treatment-resistant cancers. And we know that of these men, up to 90% will end up with disease that spreads to places like bone or liver. And unless we improve how we manage and treat these aggressive cancers, it has been predicted that up to 700,000 men will die of prostate cancer each year by 2040. So even though for a large proportion of men living with prostate cancer, things really aren't this grim, for many men, this is a reality. And this is something as researchers that we would really like to change. Now, what we do know is that the challenges associated with treating metastatic or advanced disease, particularly cancer that has spread to bone, mainly stem from a lack of reliable and easily measured biomarkers, so a biological marker that allows us to predict which men are most at risk of disease progression. And so currently the most commonly used biomarker is PSA, or prostate-specific antigen, which this is released into circulation by prostate cancer cells, and it's measured by doing a blood test, which I'm sure many of you have already had. Now, PSA levels generally go down when things such as hormone deprivation therapy is working, and go up when resistance to therapy is starting to occur, or when the cancer begins to grow too rapidly or spread. But the problem is that this blood test doesn't work for everyone. So in some men, PSA may be high without drug resistance or metastasis, or more commonly, it may actually remain low even if metastasis has already occurred. And so we need more reliable biomarkers that work for everyone with prostate cancer. Now, this lack of cancer biomarkers means that there are also fewer targets at which we can sort of direct therapies in order to kill cancer cells. Now, the most commonly utilized prostate cancer cell biomarker that we use for therapies is called prostate-specific membrane antigen, or PSMA. And this is a protein that's expressed on the outside surface of cancer cells, and it's frequently elevated in metastatic disease, which makes it a really good target at which to direct therapies such as radiation, which has been linked to a PSMA binding protein that we call PSMA targeted radiotherapy. However, sometimes PSMA expression is low or even absent on prostate cancer cells. And so this sort of differing expression profile can occur at many different levels, which sort of confounds how effective these therapies are. So in some men, they may have PSMA positive tumors. Some men may have PSMA negative tumors. Then in the same person, some tumors may be PSMA positive and some may be PSMA negative. And then just to make things a little bit more complicated, some cancer cells within the same tumor may be positive, some may be low, and some may be negative. And as you can imagine, this poses a problem when we're trying to treat the cancer, because what we end up with is a situation where all of the PSMA positive cells can be easily killed, but the PSMA negative cells are often left behind and continue to grow. So it becomes harder to get rid of the cancer entirely using therapies that are directed to the tumor, such as antibodies or molecules that have been linked to radiation, or things like tumor-targeted CAR T cells that you may have heard of, which especially engineered immune cells that can recognize and kill cancer cells that express certain patterns or proteins on their surface. Now, we do have drugs that fight cancer that don't rely on tumor-specific biomarkers, and instead act to promote immune system responses that help our own bodies to fight the cancer. But I guess to date, these drugs haven't been particularly successful in prostate cancer, despite having good responses in other kinds of cancers that we call hot or reactive cancers. And a large part of why these therapies haven't performed well stems from a lack of understanding or knowledge about what kind of immune activating drugs might work best in prostate cancer patients that have metastatic or advanced disease. And it's this knowledge which is really critical to improving therapies that either already exist or designing new ones. And this is something that doctors and scientists only just now beginning to really grasp as technology improves and we're actually able to perform more informative studies. So this brings me specifically to the work that I do, which is to better understand what makes metastatic disease or prostate cancer cells that have taken over different organs, such as bone, so unique. Because knowing more about the tumor microenvironment, or what we call the tumor landscape, is really key to improving treatment strategies and identifying how certain cancers or cancer cells in certain organs become drug resistant or also aggressive. And so what I do is look at prostate cancer tissue from the prostate, which we call the primary tumor, because this is where the cancer begins, as well as tumor tissue from different metastatic sites, such as lymph node or bone or liver. And we access these tissues from biopsies, which you may have had done, or when men consent to have their primary tumors used for research purposes at the time of radical prostatectomy, just to see how these different sites compare in composition. And these pictures that you can see here are actual tumor tissues from men with prostate cancer that have basically been fixed and mounted onto slides that we can stain with up to 9 different antibodies that bind different proteins in different kinds of cells. And we visualize these proteins using high-powered microscopes with lasers that turn wavelengths emitted from each antibody into colored signals. And then we can count these colored signals basically like a paint by numbers, to see how cell populations or cell activity changes between different people or in response to drugs or during cancer progression. And so if you look at these two pictures on the right, what you can actually see is that all of the pink is prostate cancer cells. The green and yellow represents good immune cells. The orange represents bad immune cells, while the red tells us that the immune system is trying really hard to fight this cancer. And what you might be able to tell between these two pictures, 1 and 2, is that there is a lot more orange and red in the primary tumor from a man who went on to develop bone metastases, meaning that the fight against metastatic disease is often much harder on the body. Now, what's important is that we can compare what's happening in the primary tumor to other metastatic sites. And this allows us to sort of measure how much the tumor changes as it spreads to other organs, such as lymph node or bone. So we can make smarter decisions about how best to treat cancers that are growing in different sites, because something that a lot of people often don't realize is that a prostate cancer growing in the prostate is very different to prostate cancer growing in bone, simply because the environment in which the cancer cells are surviving is both physiologically and structurally very different. So as researchers, we use this kind of information from patient tissues to identify anomalies that inform on how the cancer has evolved in a new environment and how different environments influence the efficacy of drugs, which means how well a drug will work. And whether there are changes in certain biomarkers that are consistent enough for us to use them as a guide to make predictions about risk of disease progression or therapeutic response. And this has big consequences for quality of life, because it means that men are less likely to undergo treatments that are perhaps not going to be very successful right from the very beginning, or in some cases may make things worse. And so this will help doctors make more informed decisions about choosing the right kind of drugs that suit patients based on what their cancer looks like, that have a better chance of yielding a positive response. So I'm going to show you a few of the things that we've discovered about the tumor microenvironment in metastatic patients, particularly bone, because these are the hardest tumors to treat. And not only am I showing you this because it's pretty amazing from a scientific point of view, but also because it helps explain why metastases in bone pose such a big challenge to currently available therapies. This may feel a little bit complicated, but I'll try my best to explain it in simple terms. And so what you're looking at in this top panel are zoomed in sections of tissue from a prostate tumor on the left, a lymph node metastases in the middle, and a bone metastases on the right. And all of these individual colored circles are different immune cells in the tumor microenvironment. And you can see that there are plenty of these red and blue cells. And these are the two major types of T cells that under certain conditions can actually kill tumor cells directly. Now, when these tumor cells are activated, meaning that they have encountered a cancer cell that they both recognize and can remember and are ready and armed to attack, they should give off an orange signal. But what you can see here in these pictures is there really aren't any orange cells at all in these different tumor sites. And we see this graphically as well. So what this means is that prostate cancer in general has a low T cell activation status. Even though there are lots of T cells there, they aren't actually really doing anything. And this means that a robust anti-tumor immune response may be very difficult to generate. Now, what we see is really different about bone specifically is sort of represented in this bottom panel, where you can see in this right-hand image that there are a lot of pink cells. And these pink cells represent T cells that are suppressive. And so basically what they do is they block good T cell responses. Now, we find these cells by looking at a molecule called FOXP3. Basically what they do is that even when these cells up the top do manage to launch an immune attack against cancer cells, these cells in bone can actually switch those responses off. Now, what we also see in bone is a loss of what we call checkpoint proteins that are found on both immune and cancer cells. These checkpoint proteins basically do what their name suggests, and they act as a checkpoint. And they terminate T cell activity before autoimmune problems arise, and the T cells basically start killing healthy cells in the body. Now, these proteins, despite having a very important normal function, have a bit of a bad reputation in cancer because they can also block T cell activation and prevent T cells from killing cancer cells as well as healthy cells. Now, these proteins are generally upregulated following T cell activation, and this has been a really good thing in some kinds of cancers like melanoma, because we have therapies called checkpoint inhibitors, which you may have heard of, that can be used to effectively help prolong T cell activity against cancer cells, giving them a better opportunity to kill a cancer cell before their activity gets switched off. But what you can see in these left-hand images is that there aren't any green signals in this picture down the bottom, which is a bone met, compared to the other tumor sites. And these green signals represent checkpoint proteins. And this means that in sort of metastatic lesions, particularly those in bone, is that checkpoint proteins aren't being made. And this makes sense because checkpoint proteins only go up in response to immune activation. And if you remember back to the previous slide, there really isn't any immune activation happening in bone metastases at all. In fact, there's the opposite, so there's immune suppression. Now, the implications of this is that there's basically nothing in bone metastases to target with a checkpoint inhibitor. And this is why, despite being used in clinical trials in prostate cancer, these kinds of drugs haven't worked very well. And so now we're working to see what we can combine these drugs with to increase their therapeutic efficacy, because they've worked really well in other cancers. Another thing that's lost in bone metastases compared to other metastatic or to other prostate cancer sites are molecules called antigen-presenting markers or proteins. And basically what they do is they make tumor cells visible to the immune system by displaying chopped up parts of the immune cell, of the tumor cell for immune cell recognition. Basically like holding up a sign that says, "Here I am, come and get me." And these signs or signals not only allow cancer cells to be found in different places of the body, but also signal to immune cells that a cancer cell needs to be killed, and allows the immune cells that kill them to actually remember certain features or patterns about the tumor cell that helps to protect against disease if the cancer ever comes back in the future. And so just to summarize the last few slides that I've shown you, we know that one, T cells are not doing a very good job of killing cancer cells in bone metastases. That two, there are no good immune cell targets that we can send drugs to in order to help the body fight the cancer. And three, that prostate cancer cells in bone are largely invisible. Now, what makes things even more challenging is that there are immune cells called myeloid cells that under normal conditions basically just help the body clear infections by cleaning up all the debris like dead cells and mucus, because the cells in our body are naturally dying all the time and they're being replaced. But in cancer, these cells actually cause a lot of inflammation, and they create an environment that is generally suppressive or inhibitory to all good immune responses. And you can see these immune cells in the bottom picture on the left-hand side in aqua, and they're really abundant in these bone metastases, but they're not so prevalent in either the primary tumor or a lymph node metastases. And we can sort of represent this graphically as well. And basically what all of this does is promote a place that supports cancer growth and helps turn the prostate cancers in bone into what we call an immune cold tumor, by fostering an immunologically unreactive microenvironment. So how can we overcome this to help fight cancer in bone? Well, one of the things that we're currently working on is using radiation-based strategies to make prostate cancer in bone more targetable. And one fantastic thing about targeted radiation therapy that we're only just beginning to understand, because these therapies are quite new, is that they do a lot more than just kill off cancer cells, which is what they've been traditionally used for. So they can also promote really strong immune responses by increasing antigen presentation. So all of those come eat me or come find me signals on the tumor cells. And this sort of in turn helps T cell activation and general immune activation, which helps tumor cell killing. But like so many other things in life, you get a little bit of bad with the good. And the bad that comes in response to radiation is that in the process of killing off so many cells at the tumor site, it tends to make the tumor site unstable. So basically what this does is create a void that's most easily filled by whichever cell population is currently thriving, which in the case of metastatic cancers is often those suppressive myeloid cells or inhibitory T cells. It also activates immune signaling pathways in many different cell types, including myeloid and tumor cells, which cause an increase in those checkpoint proteins. The good news is that we can block or decrease these kinds of unwanted responses with therapies that block bad immune cell signaling and inhibit checkpoint proteins in combination with or after radiation. And we're sort of now exploring which drug combinations to sort of mediate all these kinds of responses have the least side effects, as this not only helps the patient feel better, but it also means that men are maybe more inclined to stick with their treatment schedules, which may inevitably improve drug efficacy and delay drug resistance. Then what we can do is take the safest combination of therapies and test which works best against metastatic tumors, with the intention of basically changing these immune, cold, unreactive tumors into tumors with potent and reactive anti-tumor immunity. Now, importantly, we're also looking beyond tumor targets, such as PSMA, to new targets that we've identified on prostate cancer cells, including ROR1 and B7H3, which you may have heard of, that may help us overcome the failure to eliminate PSMA low, negative, or mixed tumors that will basically offer better disease control long term. And we have a fantastic team of more than 30 clinicians, chemists, and researchers currently working on identifying new prostate cancer targets and developing drugs against these new targets under the banner of a tactical program at Peter Mac, which is funded by the PCF. Now, one thing I'd like to end on is a bit of a snapshot of what happens to the tissues you consent to being taken or collected if you partake in a clinical trial. Because I think a lot of patients may agree to have these samples taken, and then they're never really told what happens to those samples or why those samples are being used, or what kind of results we're getting from those samples and why they're so important. So when your blood is taken, basically what this does is it allows researchers to assess how well a drug is performing. And so we might compare pre-treatment and post-treatment samples over time to see if more tumor cell antigens are being presented, or if T cells are being better activated, or if checkpoint proteins or druggable targets are being increased in response to treatment. And so here you can see some data from a clinical trial looking at PSMA targeted radiation. And what we can see that it's doing is it is increasing antigen presentation, it is increasing T cell activation, and it is increasing the number of targets that we can go in and drug with other kinds of therapies. We also look at what the immune system looks like in men who have good responses versus men who don't have very good responses. And this sort of helps us understand why some people don't respond to certain kinds of therapies, and may allow us to identify early patterns or changes that indicate that a treatment isn't going to work well before the treatment actually stops working. Now, the tissues that we assess, which come from biopsies or surgeries, importantly, what's telling us what's happening right at the tumor site. And this sort of allows us to catalog key changes during prostate cancer progression, that we can use to not only understand why or why not a particular treatment approach worked or why it didn't, and what can be improved, but also importantly, from those pre-treatment samples, we can also identify biomarkers that may already be there in these patients that indicate that a cancer is going to spread to bone before metastasis already occurs, so that we can intervene much earlier. So basically, my job as a prostate cancer researcher is to assess what's happening in the blood and the tumors of men with metastatic cancers, take those findings and work on improving existing treatments or developing new ones, all to achieve better outcomes for men with metastatic disease, not only in terms of improving survival and therapy responses, but also allowing earlier intervention through predictive information that we're hoping will really improve quality of life. And so I work with a team of really amazing people at Peter Mac across many different laboratories. And we work with a lot of clinicians, including Michael Hoffman and Arun, as well as sort of collaborators from other institutes. And we work quite closely with our funding partners, so the PCF in America and the PCFA in Australia, and they're sort of really key to ensuring that we can actually afford to make all of this research happen.
Wow, that's a lot to absorb.
It is quite a lot. I thought it might be a lot, but I really wanted to give you a bit of a snapshot of what we do, because I talk to quite a few consumers, and you know, quite often they only have discussions perhaps with their clinicians, or they have discussions with each other, and they never really see the research side of things. So, you know, when all these tissues get taken, when their blood is taken, what happens with that? What does it all mean? What are we doing with it? And so I think it's really important for people to know that we are doing very important things with those kinds of samples, and those samples sort of really enable us to do this kind of research.
No, that's fantastic. Does anybody have any questions? Alan, you're on mute.
Yep. Thanks for that, Katie. That was fantastic. And I think you pitched it exactly right. Balance between detail and overview. That was a terrific presentation, I thought. I just wanted to get an overview comment, because I do have to go a bit early, unfortunately, but an overview as to where you think we're at in terms of actually being able to successfully treat both lymph node mets and bone mets. It's quite interesting, the distinction you made between those two in terms of the microenvironment. And I'm just wondering if you've got any educated guess as to how far away we are for successful therapies on each of them.
Well, I think one of the difficulties with this kinds of research is that traditionally, and this is right up until quite recently, for a lot of people doing this kind of research tended to focus on the primary tumor, so the primary prostate cancer. And basically, a lot of what people were sort of assuming was occurring in different sites, you know, so like bone or liver or lymph node, it was actually based on information that was coming from the primary tumor. And now what people have started to understand over the past sort of 5-10 years is that those tumors are very, very, very different tumors. And so they need to be treated differently. And so it's sort of, it's still in the very early stages, even though, you know, a lot of these therapies have been around for a long time, because they have been focused on primary tumor alterations. So now that we understand that metastatic tumors are very different, they need to be treated very differently, people are starting to do metastasis-focused research, and that's what I do. But still, there are not enough people doing this kinds of research. One of the good things, I think, at Peter Mac is that we work really closely with the clinicians, especially in the nuclear medicine space. And they also understand that especially bone metastases are very different and they need to be handled very differently. And so some of the more targeted therapies that we're trialing now and that we're developing are really focused on treating these cancers at a particular site. So I think over the next sort of 5 years, we're going to see some really fast improvements on better treating these kinds of cancers. I don't think it's something that's going to happen in the next couple of months, but I think that we're actually, for probably the first time, really starting to develop better therapies with the understanding that these kinds of cancers need to be treated much differently, and we're able to develop things that can do that.
Thanks, Katie.
Mm.
Katie, Tony Maxwell here.
Hi, Tony.
G'day there. Just a question that comes to mind from your presentation. You talked at various stages about PSMA and radiation combination.
Yes.
What sort of radiation are you talking about there? Is it a specific type or generally?
Yeah. So it's not, I mean, I think a lot of the time when people think of radiation, they think of external beam radiation. So that's the kind of radiation that may, it's sort of directed to you from outside the body. You have to go in a particular machine, and basically in sort of very, very basic terms, it hits you with a beam of radiation. Sometimes they can use computer-directed equipment to make sure that that radiation is targeted to a specific site. But some of the radiation that I was talking about today is radiation that is sort of put into the body. So it's injected in IV. And basically what it is a radio isotope, so a very small radioactive molecule that is often joined to a particular protein or drug or molecule that has a very high affinity for a particular target. So when we talk about PSMA targeted therapy, basically we have a small radioactive radioisotope. It's linked chemically to a very small molecule that has a very high, very specific affinity for PSMA. And so when you inject it into the body, it only goes to cells expressing PSMA. And that's the benefit of sort of targeted radiation, because you don't get a lot of those off-target effects of introducing radiation into the body, and it's going to impact basically all your cells. So the idea behind targeted radiation therapy is it doesn't, it doesn't have such negative side effects. It delivers a very high energy, potent radioactive dose right at the tumor site. And so if you're fortunate enough to have PSMA positive disease, these kinds of therapies work amazingly well. But the problem with prostate cancer, and this has always been the case, is that it's a complicated cancer. And so you have a lot of heterogeneity in the environment. So a lot of those cancer cells, even though they're all prostate cancer cells, sometimes they look a little bit different from each other, even in the same patient. And so that's why these kinds of targeted therapies sometimes don't work, is because you might be sending these drugs into a patient that doesn't really have very good PSMA expression. So that's why we're looking at alternative markers that can be used to potentially sort of overcome some of those challenges when men have PSMA low disease or negative disease. We can use an alternative like something like ROR1, or we can send those drugs in together so it sort of has a double whammy effect. And then you sort of are in the situation where you don't have that many negative tumor cells left behind.
What about stereotactic radiation? Is that
That's a little bit different. So that's still sort of, I guess, considered external beam.
yeah.
And it still comes with, you know, a lot of the side effects of basically if you're shooting radiation that's not targeted at anything, what you're going to do is wipe out a lot of cells in the crossfire that you really don't want to wipe out. And that includes a lot of healthy cells. It includes a lot of immune cells. And so you might be killing a lot of cancer cells, but you're also killing a lot of cells that you need in the process.
Mm.
And so sometimes what that means is that after you might have had external beam radiation, if you're in the situation eventually, if your cancer returns or it starts coming back, you don't have those immune cells there that are ready and armed to fight the cancer because basically you've wiped them out with the radiation.
Mhm.
And so that's, you know, starting to use targeted radiation is sort of where radiologists are leaning towards now. But the problem is that it, you know, it's not available to everybody. It's still something that most commonly is in clinical trial. We're very fortunate in Australia that we're the third leading country doing this kind of research in the world. But you know, for people in sort of smaller countries in Europe and places like Africa and a lot of Asian countries, they don't have access to this kind of technology. And so when we talk about the incidence of prostate cancer increasing and mortality increasing way into the future, it's often coming from a lot of those countries that don't have access to this kind of technology.
Mm. Thank you.
Anyone else with any questions?
So, Katie, are you talking about lutetium-177 or PB212, things like that?
Yeah, so we you probably know what Michael Hoffman, the work that Michael Hoffman does. So he does a lot of the clinical trials at Peter Mac, and we do clinical trials with lutetium. And we do clinical trials with terbium. And the tactical program that I mentioned, which I'm part of, we are now exploring lead, so the PB212. And so we've started doing the first preclinical experiments using lead, which we think is going to be a much better alternative to lutetium, because it's basically higher energy. Actually, let me show you something. Let's see. I've got a bit of a slide here. Just let me share this slide again because it's going to explain exactly what I'm talking about. So can you see this slide here?
Yes.
Yep.
Okay. So basically, this is talking about improving the delivery of radiation, and this is based on different kinds of radiation. And when you mention lutetium's a beta emitter. And what that means is that, I mean, the good thing about lutetium is that it has a long half-life. And so when it enters the body, it basically hangs around for quite a while. And it's active for quite a while. But if you sort of have a look at this molecule at the top and imagine that this is your tumor cell that has, you know, if you want to say this is your tumor cell that's expressing PSMA and this is what your lutetium has been targeted to, what it does is it emits radiation at the tumor site, but it has a recoil effect that basically travels up to 1 centimeter. And so what this does is not only kill off the tumor cell that it's been directly targeted to, but often in the crossfire, it will wipe out not only other tumor cells, but it starts to impact healthy tissue. And then, you know, say if this is in bone, it might impact your bone cells. It might impact the structural integrity of your bone. but more commonly, it's going to wipe out the immune cells that you really need to sort of launch good immune responses after your therapy is stopped. Now, lead is an alpha emitter. And what alpha emitters are, they have a really, really high release of radiation energy over a very short path length. So what that means is that all of these cells beyond sort of 100 micron range, which is really only a couple of cells in distance, it spares all of those target negative cells. And so what that means is that all of your sort of good immune cells that you really need to be preserved are preserved. And so that's sort of one of the things that we're hoping will be a benefit of using these new alpha emitters like lead. I'm about to be involved in a trial that's starting at Peter Mac using actinium, which is another alpha emitter. And what we're going to do is some investigation to see, how beta emitters compare to alpha emitters, which is the best at eliminating the cancer, which is the best at reducing side effects. But perhaps most importantly, and this is something that we don't know yet because this is all very new. So lead hasn't even gone into proper clinical trial yet. They've basically just done their sort of first inpatient safety assessments. And so when we start doing our preclinical work and more of the clinical investigations with lead, we'll see importantly whether when we treat with lead, we can get a durable response. Because one of the problems, the focus on therapy tends to be having these very immediate, very acute responses, which is fantastic. You treat and you have these amazing responses and all the tumor cells are wiped out. But one of the problems is that with radiotherapy, most of the time, inevitably, these cancers come back. And so what we're hoping when we start using these new alpha emitters is that they can either delay the return of the cancer or they can stop these cancers coming back completely.
So, Katie, where does that leave radium-223?
Well, radium is still being used, and we have, I'm sort of involved in a clinical trial with Michael using radium in combination with lutetium, because the benefit of radium, especially in bone metastatic patients, is that radium sort of in very, I guess, crude terms, looks like calcium. And it acts like calcium. And so when you put radium into the body, you have a really high uptake in bone, because in bone, there's a lot of calcium turnover. And so what that does when you put radium into the body, particularly if it's linked to something like PSMA, is it tends to take that radium directly to bone. And so that's one of the benefits of radium. And so most of the time with radium, we combine it with something else, such as lutetium, or in the future, perhaps lead or actinium, to see if we can not only have a tumor-targeted effect, but also more of a bone-targeted effect, just in case there are any sort of target negative cells hanging around in that bone microenvironment.
And for the cancer cells that are not PSA emitting, I understand that they can be picked up via FDG scan.
Yes, yes. So they can be picked up by scan.
Is there?
So they can be picked up by scan. But the problem is we need a way to be able to treat them.
Okay.
So we can definitely pick them up by imaging, but then treating them is a little bit of a different sort of thing.
So currently, is there any research going into linking some sort of isotope or whatever to an FDG process?
No, because that basically just relies on a metabolic profile. And so what you might get with that is a lot of unwanted side effects. And so what we're trying to do to eliminate what we sort of would prefer to do to eliminate those cells that are, say, target negative, is really combine them with therapies that can help the immune system sort of activate and be able to fight off those residual cells. Because even with FGD, you still will miss some cancer cells. And the problem is that it only takes a few cancer cells left behind for the cancer to return. And so the only way that we think that we can sort of get rid of everything is if we arm the immune system. So we want to debulk the tumor, basically, with some of these radioisotope therapies. It's going to get rid of most of the cancer cells. And then we want the body's own immune system to have the tools to be able to come in and mop up the rest.
And one of my friends was in a trial with multiple treatments with lutetium, and he complained of effects to his salivary ducts and his tear ducts, yeah. and I anticipate that the newer options you're exploring with lead and actinium, A, would they reduce those side effects, and B, would they permit a more repeated treatment again and again and again than with lutetium?
So those kinds of drugs, yes, you can use them more regularly because they have shorter half-lives. But the problem with the sort of salivary gland uptake and things like that is not because of the radiation so much as the fact that your salivary glands just naturally express PSMA. And so basically you're sending your radiation to the cancer cells, but you're also sending it directly to the salivary glands. And so one of the off-target effects of that is that your salivary glands are also receiving radiation. So it's not so much a problem with the radiation per se, it's a problem with the target that the radiation has been attached to. And so when we are looking at and developing new targets, one of the biggest things that we need to make sure that the requirements that these targets are meeting is that they're not expressed on any other cell in the body. And that's really hard because you find that in the body, most things are expressed on some cell that is really important somewhere. And so, you know, I mean, some cancers, some people are really fortunate that they do have very, very treatable cancers purely because they express something that is exclusively only related to that particular cancer. But with prostate cancer, it's a little bit more challenging because prostate cancer cells, just by nature, express a lot of things that are expressed on bone cells. And that's why they have such a high affinity for bone. That's why they like to grow there, because they actually naturally express a lot of things that just your normal bone cells express. And so when we're developing new targets, one of the things that we're hoping that will change is the xerostomia associated, like the dry mouth associated with PSMA sort of lutetium or PSMA. I think it will probably happen with anything actinium, lead. It wouldn't matter what you link it to.
Thank you. Any questions, fellas?
Yes, I have a question if I could.
Mm-hmm.
Katie, first of all, thank you for the talk. Very interesting. And to hear the latest research and this stuff really is good for us. My question is, are there any clinical trials occurring where they're mixing radionucleotide actions with immunotherapy?
Yes. So there's numerous trials at the moment, and there's been trials happening over the last couple of years. One of the problems that is still being encountered in these trials is that they've sort of mainly been limited to using these beta-emitted radioisotopes, so lutetium. And so in effect, by using the lutetium, what's happening is they're often wiping out a lot of the immune cells that the immunotherapy component of the therapy needs to act against. And so what we're hoping with the newer types of radiation, when you start sort of salvaging some of those immune cells, that when you combine with an immune activating therapy, that we're going to see better results. But that kind of research is underway. I'm involved in a lot of that sort of research. I mean, just like there's all kinds of new radiation therapies, there are all new kinds of immune therapies. And some of the immune targeted therapies that are just emerging now look really, really promising. So it is kind of an evolving area of research. And I think that what comes out in the next couple of years is going to be a lot better than what we've been working with.
Yeah, certainly immunotherapies have been remarkably successful in lots of different hard tumor cancers over the last 5 years. So it seems a logical thing to try and link the two. But as you say, prostate cancer is so much more complex because of different nature of metastases. So
yeah, so that's the problem. I mean, I have friends that work in melanoma and myeloma, and they use a lot of these immunotherapies, and that's honestly where they were first used, and they've been incredibly successful. And it's just because those cancers are more amenable to those kinds of therapies because they express all the types of features that you need for those therapies to be successful. And I think it was probably potentially maybe came from a sort of hopeful position, or it was something that was perhaps too rapidly implemented, where people thought they could very easily take a therapy that's very successful in one type of cancer and then apply it to all cancers. And then they realize very quickly that you can't do that because all cancers are basically very different. And so now we're just figuring out how to make those therapies that have been so successful in other cancers work better in prostate cancer, because it's not that they're bad therapies, they are good therapies. But prostate cancer just doesn't have the profile for those to work really effectively.
Okay, thanks, Katie. That's great.
Any other questions, guys?
Only shared.
Sorry?
Hello, can you hear me?
Yep.
Thanks for your talk, Katie. Very informative. It's a bit scientific for me. What I'd like to know is, are you still recruiting for your clinical trials?
Well, I know that I don't think we're recruiting for the lutetium and terbium trials that we have on at the moment, but I know that they are going to start recruiting for the actinium trial that's starting at Peter Mac, probably in November. It was supposed to start in July, and then it's been pushed back. So I think now the planned start date for recruitment is November or December. But that hasn't, to be honest, it hasn't been sort of publicly announced yet. So that's a little bit of inside information. So I think the best thing to do would be to keep in contact with your urologist or your physician to see whether he can keep you up to date or she can keep you up to date with any clinical trials that are actively recruiting at Peter Mac. But I know that there are going to be some more towards the end of the year.
Okay, thank you for that. Also, I assume that these clinical trials are trying to contact men who are got bone cancer specific metastases.
Yes. So most of these therapies, these clinical trials are really sort of targeting bone metastatic disease. I think they will take men who have visceral mets, but they are predominantly geared towards bone metastatic disease specifically. Yeah.
And the criteria for that would be spelled out on the clinical trial application, I imagine.
Absolutely. Yeah. So the exclusion and the inclusion criteria is very clear.
Mm-hmm. And where would the physician involved in it get that information about the availability of that trial?
Oh, to be honest, I have no idea. I'm sort of not involved on that side of things and in the recruitment process, because usually that's driven a lot of the times by the pharmaceutical company that's sort of driving that clinical trial. And this one is sort of coming from the States. And so maybe something that we can keep you posted on in the future, or that, because I know that it will eventually be going through some of these trials in the future will be going through Peter Mac. You may be able to get that information through the Peter Mac website.
Yeah, that was what I was thinking. So that was the answer to my question. Thank you, Katie.
Katie, recognizing that many of the people on this Zoom call are from Queensland, would there be any local Brisbane or Queensland locations?
Well, I know that with some of the clinical trials that we run out of Peter Mac, that they do have partner hospitals and partner institutes. And so depending on the infrastructure of whichever sort of hospital is hosting the trial, there may be something up in Queensland. But unfortunately, for a lot of these kinds of trials, I guess the provisions and the specialized equipment and the specialized sort of nurses and radiologists, they're not available everywhere. So it is quite specialized medicine delivery. And so I'm not sure what that sort of landscape looks like up in Queensland. But I know I have a feeling that with one of the trials that is going to be coming out with lead, that they do have partners up in Queensland. I couldn't tell you where. They do?
Yes.
Yes, yeah.
At the Royal Brisbane and Women's Hospital.
Yeah, right. Yeah. I mean, I know just from working with a lot of the men that come to Peter Mac is that they do come from interstate. We get a lot of people coming from interstate. But I know that some of the trials that are coming up sort of within the next 12 months, I know that they at least have partners in Queensland and Sydney, but I just couldn't tell you where.
Great. Great, thank you. Fellas, personally, I've run out of questions. So passing over to you, if any of you have any further queries to make of Katie. She's been terrific with her presentation, been extraordinarily informative, and all I can do is say a great big thank you to you.
Thank you.
Your
Thank
time
you
with us
for
and
inviting
sharing that
me and
information.
listening.
Looks like Tony might have something to say. Tony Maxwell.
I think he's just clapping.
Thank
All of us are clapping.
Well, indeed, then we all should clap.
you. I will say that, you know, if you think of any sort of questions over the next couple of days, or if there's anything that you didn't want to ask out loud today, you can, I'm quite happy for you to pass on your questions to either Nev or even I've been speaking to Tony a little bit in the past, and they can pass it on to me. I'm happy to answer any questions outside of today. Yes.
Sorry, Katie, do you mind going over again how you identify which cells demonstrate the PSMA protein? You said some have it, some a little bit, and some don't.
Yes. And so what we can tell by that is doing basic scans. And so when you have your scans, your PET-CT scans, what they can often use is like a PSMA PET, and that will light up all of your PSMA positive disease, but they can combine that with other types of scans that will also light up all of your total disease, including the PSMA negative disease. And so that sort of tells clinicians right from the get-go how much of your sort of tumor burden is actually PSMA positive or is PSMA negative. So that's what we do in sort of like whole body scans. And so we can tell that from, you know, from the outside without anything too invasive. But then when we really want to get down to the molecular level, we actually need to take biopsies. And so that tells us more about, on a real single cell level, you know, how many cells in your particular tumor are PSMA positive and PSMA negative, because scans still just don't have that kind of resolution to get right down to that single cell level.
So that's important. So if it's not showing up, what's the result of all of that? If you just don't see them, they can still progress?
Yes, and that's often what happens. And that's often why you do have sort of progressive disease, even in men where, you know, their scans might suggest that 90% of their tumor burden is PSMA positive. There still might be that sort of 2, 5, 10% of burden that isn't. Now, depending on what kind of drugs and what combination of drugs you go in with, you might be able to take out that PSMA negative disease. But it does come with the risk of those cells being left behind, and then they're the cells that eventually outgrow, and then your cancer comes back.
Okay.
So, Katie, I thought of a couple more questions.
Yep. I've got time.
Are there any replacements to gallium on the horizon that will be more sensitive?
Yeah, so there are. So there's some pretty good advances being made in different kinds of imaging isotopes. We sort of do a little bit of that work in preclinical models at the moment, but at the currently, gallium is still one of the better options. So one of the things that we have to be careful of with imaging, and we're sort of looking at different isotopes and things like that, is that they need to emit a certain kind of radiation wavelength or signal that can be picked up with the machines and the technology that we have currently available. So I think one of the major setbacks or something that's currently holding up that kind of advancement is the technology that we actually have available to image those kinds of radioisotopes. So it's more not necessarily about actually replacing the radioisotopes, but actually improving the actual equipment used to detect those kinds of radioisotopes. And we've got new equipment coming out all the time. It's fantastic. The problem is really actually quite logistical. So when new equipment comes out, we need new permits, we need new ethics, we need to test that it works. We need operators who can actually use the equipment. So it often comes with specialized training. And so that sort of creates a little bit of a delay in implementing these kinds of new technologies. We've got some new machines that are being delivered potentially to Peter Mac next year. And it's not as simple as, we've got the money, these new machines are fantastic. But what it means is that we have to actually change the structure of some of the rooms in the building to be able to house that equipment. And so that's a huge rebuild.
Oh, wow.
It's a refit. And so it's not often as easy as just like something exists, let's put it in and use it. It can take 12 months just to create a room that can house these kinds of machines because they're so high powered. And they're so sensitive that, even just sort of the wrong vibration in a room next door might alter the resolution of the scan. So it becomes a little bit of
fair enough.
a logistical and infrastructure issue.
And this is my final question. So the neuroendocrine cancers that turn up from time to time, PSMA emitting, correct? And they remain the undetectable ones.
Sorry, your connection cut out a little bit there. Can you repeat?
If someone has a neuroendocrine cancer, they still remain the troublesome child.
Yes. So I actually have an amazing student who is working on neuroendocrine prostate cancer at the moment. And some of the data that is coming out of this project is quite amazing. And so what we're doing with this project is trying to identify new markers that tell us about neuroendocrine disease when it's transitioning from adenocarcinoma to neuroendocrine. Because that's where it gets lost. It gets lost in that transition phase where it stops expressing your sort of traditional prostate cancer markers, and it might not be picked up anymore, and it sort of goes into hiding. It's that transition phase that's really critical and sort of allows it to escape and go on and become really, really aggressive, because it's one of the most resistant forms of prostate cancer. And so at the moment, there's a lot of work that's been done to try and identify, I guess, indicators of that switch. So that switch from adenocarcinoma to neuroendocrine prostate cancer. And so I'm hoping, we're going to publish this work probably next year. I'm hoping, but I know that a lot of other people are working on this. And I think that it won't be as challenging, within the next 5 years as it is currently. I think it's going to be much easier to target and much easier to identify. And I mean, I suppose I have to be a little bit careful in saying this, but one of the reasons why neuroendocrine disease has become such a problem these days is because our way of handling, managing, and treating adenocarcinoma has gotten so much better over the last 30 years that men are surviving much longer with prostate cancer. And so that prostate cancer actually has the opportunity to evolve. 40 years ago, we didn't really see neuroendocrine prostate cancer as much because the men with adenocarcinoma had a much worse prognosis. And so they didn't even get to the stage of having neuroendocrine prostate cancer. And so that's why we're only sort of seeing this rise in neuroendocrine disease now, is because men are just living much longer with prostate cancer. Which, it's both a good thing and a bad thing.
Yeah. Well, it's good to hear that things are afoot. So
yeah, no, I think that there's going to be some major advances in that space over the next few years, and I think it's going to be sort of maybe taken out of that too hard basket, and it's going to be something that we can manage much better.
Super. Well, I, for one, would like to thank you again for the second time for a marvellous presentation, for making yourself available to answer all of these questions. It's an incredibly useful opportunity for guys like us to get a better understanding of where the future lies in terms of treatment, and understanding, what the mechanisms of cancer spread are. So I personally dips my lid to you, and I'm sure all of the other blokes on this call are most grateful for your making your time available, and thank you again. And
yeah, thank you for having me. And I was sort of hoping that I could maybe learn a little bit more about the group, and I'm happy to come back to these meetings and have a chat at any time. I'm really I'm happy to share what we're doing and keep you updated. I'm always happy to talk about research. So, if there's any interest in the future, I'm happy to come back, tell you about the latest clinical trials, tell you what's going on in the prostate cancer space, and hopefully each time come back with better news. Yeah, just reach out and let me know if you have any questions, or if you have any stories to share. I'm available.
You would be most welcome to participate anytime you like, I'm sure. And of course, you're most welcome to remain on the call for its duration if you want to hear about the profiles of any of the guys on this call.
Oh, are you continuing this meeting now?
Yes.
Yeah, we generally go through to about 12 o'clock.
Yeah, right. Okay.
And discuss, various issues associated with guys who want to speak up and explain their personal circumstances. So,
are people comfortable? Everybody.
I hope I'm not presumptuous, Jim, in making that offer, but I don't think I am.
Is
No.
everybody comfortable if I hang around for 10 minutes? I have to jump off at 11:15, but I might hang around for a few minutes.
Okay, thanks for that, Katie. Yanni, there are some people who are just new and have specially joined to give their first talk. For those who aren't in a real hurry, the next meeting will be in 3 weeks' time on Friday, September the 27th. So anyone who hasn't told their story and would like to start now, please identify yourself by speaking up. There's Ross Chapman, I can see. Yanni, you're going to be running these. We'll start with Ross then, Yanni, if that's all right.
Yep, no problem at all. Go for it, Ross.
Thanks, Jim. Thanks, Yanni. Yes, this is my first Zoom meeting. I've had a look at a few of the recorded meetings, and I'm very interested. My particular journey started in November 21. I had a diagnosis of prostate cancer. Biopsy showed Gleason 9, and had the radical robot-assisted prostatectomy. I then did 37 days of radiation, external beam radiation, plus ADT, hoping that was the end of it. Of course, as I measured PSA at the end, it started to rise again. And so I've now had to go on to ADT again. I'm on Leukerin and darolutamide, have been for about 10 months. I've had PSMA PET scans, I think 2 or 3 at least, 2. The frustrating thing is they're negative. So the scans are always negative, but the PSA is rising. And while I know that might sound like good news, no tumour to be seen, it's actually quite emotionally frustrating because you're not quite sure what's going on. Where is it? The radiologist suggested that the ERBT made sure that there was nothing in the prostate bed, nothing in that part of the body. So the question I have is, where is it? And how do we know, given that the PSMA PET scans only detect things down to about 4 mil, lesions down to 4 mil? I have got some metastases somewhere. I don't know where, and I'm suffering through ADT and darolutamide because of that. And I don't know how long it'll last. It depends on how long the cancer stays castrate sensitive, I assume, reading into it. And how long that lasts is also a question for me. But I'm learning as much as I can, doing my research, very interested in immunotherapy because I'm about to start some immunotherapy for psoriasis. And the linkage between the psoriasis treatment and the prostate cancer treatment has got me very interested. I've been looking up research around that. In Italy, there is some clinical trials going on for people with prostate cancer and psoriasis, and they're looking at the results of that. So that's what I'm about to start next month, a combination of the two. And I don't know of anyone else that has those two things together, but I'd be very interested if people do. And any feedback we have around my situation at the moment, which is, yes, I've got metastases, I don't know where they are.
So, Ross, what was your Gleason score?
It was a Gleason 9.
Yeah, and what PSA level are you at now?
Undetectable, the last test.
So seriously undetectable, like 0.0010.
Less than 0.01, which they claim is undetectable.
Yes. Okay. I personally don't have any view to put forward to you, other than perhaps an FDG scan may be useful, because as we discussed earlier, if your cancer cells are not PSMA emitting, then they by an FDG scan. Katie, do you have a perspective?
Oh, is there, just for clarification, is your PSA negative or your PSMA negative?
PSA, the standard PSA blood test is
Your blood test, your PSA blood test is negative.
or undetectable, yeah.
Undetectable. And you're on ADT at the moment.
ADT and darolutamide.
That to me would suggest that your ADT is working.
Yeah, absolutely, it's working.
And so was it before you went back on the ADT that you had a rise in PSA?
Correct, yes. After the first 6 months of ADT plus radiation, I thought it was gone, but I waited for another 3 months and PSA started to rise again. So we go back onto ADT with the addition of darolutamide.
What did it get up to when it started rising?
Not that high. It was only about I think it was 2, but the doubling time was very short. So I started off very low, but doubling every month. So
I mean, so I can only sort of, loosely comment on things like this because I'm not a medical scientist. I'm not a medical doctor, and I wouldn't want to give you any sort of advice that wasn't right. But I would say that if you are back on ADT and your PSA is 0, that it's working pretty well. The problem's going to arise if you remain on ADT and it starts climbing up again. Then you may want to have further scans to see if they can identify lesions in other parts of the body. But at the moment, sometimes with PSA, and this is why it's a little bit of an unreliable target sometimes, is that it does fluctuate. It can go up and down, particularly when you've been on certain kinds of therapies and you stop these certain kinds of therapies, or you just have a change in your situation, or you get sick or something. It can cause some fluctuations in these kinds of things. And so if you are currently negative, I would probably just suggest keep getting your blood tests done. Really stay on top of that, but it does sound like it's working.
Yes, no, I absolutely agree it's working. I guess the issue is how long will it be before the cancer becomes castrate resistant, and then it starts growing again.
That varies. Yeah, that is the unanswerable question.
Yeah, thank you.
Can I follow on from Ross's question?
Jim and Rob have their hands up. So.
Okay. So thanks for that, Katie. Ross, a question first. When your PSA started rising again, did you go on the Leukerin first and then later on the darolutamide, or did you start them both at once?
I actually started on Firmagon, Jim, and I hated it because it was so painful every month. I said, no, put me back on Leukerin, but I started the ADT at the same time the darolutamide at the same time I started ADT. Okay,
and did on the Firmagon, was there a fall in PSA?
Well, yes, it went from around about 2 down to undetectable very quickly.
Okay, so like everybody, I can't tell you how long it's going to take, but when mine returned, I didn't go for any of these more advanced drugs. They're called novel drugs by PBS. I just went on, well, Firmagon for a start, and then after about 7 years, I couldn't take any more of that. And
took me 7 weeks.
So some people give it up after just one go. It can be quite harsh. So I'm just on an ordinary hormone therapy. And I've got 7 years out of that, roughly, I think, at the moment. And I have these other steps ahead. So one of the steps that you may have when the darolutamide stops being effective is simply going on to docetaxel. You can't go on to docetaxel at the moment because of the PBS rules that say you can't. They're not going to pay for the darolutamide and the docetaxel, except for people who are newly diagnosed, not those who've had treatment. So you can be like me, and I hope you've got many more years ahead of you. But certainly we've had people with great luck with the chemotherapies. One of our members that we did lose, he had 20 doses, 2 lots of 10 doses of docetaxel. And that held it for a while, and then you're able to have it back again if it's docetaxel. And then he had 61 doses of cabazitaxel. So every 3 or 4 weeks he had a chemotherapy session, and chemotherapy treats everybody differently. You can't tell how it will happen, but for him it must have been a bit like having a haircut or your nails trimmed or something.
Well, the fact that you've lasted 7 years on ADT is good news for me, because I was thinking it would be more like 2 years. That's what I'd heard, but 7 is good. 10's even better. I'm looking forward to that.
Well, I've been 10, Ross.
Excellent. Excellent.
In fact, 11.
Trouble is, I've had a total of 15 years treatment for this. Trouble is, your body keeps growing older, and other things start.
You're right.
Okay, your life.
Rob, would you like?
Thanks, Gianni.
No, just following on from Ross's
Rob
question.
Owen?
Sorry, I don't know whether Kate's still there. If she is,
Yes, she is.
her observation, like Ross, my PSA started going up since last October. I did another PSMA PET scan, and it showed that the metastases in the bones had gone cold. They'd gone to sleep, and they didn't show up at all. Because of that, my oncologist suggested I do radiation to the primary tumour in the prostate, which I have just completed doing. It was 6 weeks of higher dosage, once a week for 6 weeks. But I'm just interested into why the PSA would be still going up when the metastases have gone cold.
The indicators that you get for PSA and the indicators that you're getting from your scans, which is looking at PSMA, they're 2 different things. And so it may be that your bone metastases have actually lost their PSMA expression, and so they're still there. They still could be growing, but you can't see them anymore. So that might be why you want to have potentially, something like combining your PSMA scan with an FGD scan, which you can talk to your clinician about or your oncologist about.
Sorry, what's this? The second one?
It's an FGG scan. It always it's like a tongue twister. FGD scan. FGD.
FDG.
Yes.
Fluoro something.
Yes.
Okay.
FDG. Because if you sort of have those 2 scans combined, it can kind of give you a better picture of your total tumor burden. So if they suspect that you do have, are they just saying that you've got bone mets by just a regular bone scan?
They did a PSMA scan 2 years ago. This last one was just June, where they didn't show up.
Right,
The
right.
only thing that showed up was in the prostate.
Yeah.
So
And you haven't had any sort of treatment in the meantime that might impact those bone metastases?
the only treatment I've been having is monthly Thermagon,
Okay.
and that's been going on for 2 years.
Yeah. Yeah, I think if your PSA is still rising, then it might be worthwhile just having a different kind of scan to see if they can pick something up again. And it may be, you know, if you are having bone scans and you can't detect sort of that there's any sort of lesions there, they just may not be very metabolically active. Or they may have shrunk in size and they're just too small to detect now by scans, but they may still be there. So there's some possibilities that you can just have some alternative types of scans.
Okay, thank you.
So just going back to Ross for a moment. You asked if anybody is aware of any linkage with psoriasis medications. Unfortunately, I'm not. It's not a question that I've heard of prior to asking it, so I'm not sure that we can be of terribly much help to you on that. However, I would like to reassure you that just because you're on ADT doesn't mean that you're about to fall off the perch. I've been on ADT, as I mentioned to you, for about 11 years. Started off with Degrelix for about 5 years because at the time that was mooted to be the thing to do. But as with you, it became too painful and my belly became too scarred for the injections to be done easily. So I changed to
Triptorelin.
Another one. Which one?
Triptorelin.
Triptorelin, that's it. And I have, but whilst I was on Degrelix, I became resistant and I had to embark on one of the newer hormone treatments, enzalutamide, otherwise known as Xtandi. And I've been on that for about 6 years now, but it's necessary to take one of the original versions of hormone treatment. So I have to be on triptorelin as well. But as I say, you know, I'm 11 years into it, and my PSA is also at 0.010 and has been for that period of time. So you've got a long way to go, Copper.
Okay, thank you.
Anyone else? Rhino, would you like to say a few words? You're, I believe, new.
Just unmute.
Demute. Yep. Good man.
Yeah, my journey started around January 2018. I went for a routine blood test, and PSA levels were around 14. March, another test, PSA, the levels had dropped to 12. The GP then sent me to a urologist, and the digital exam picked up something was wrong. I went for an MRI, and I recall reading the MRI outside the doctor's or the urologist rooms, and it was stage 4 Gleason 9. Surgery. I had surgery done, removed the prostate around July. Also, a number of lymph nodes were removed they were also, cancerous down the line. And 2019, I started, look, the PSA levels were pretty much zero until January. They were still fairly low, but they were about a 1. And I went on my first round of Zoladex January 2019, and it was terrible. It was terrible. The worst 5 months of my life. And it was toxic. There were side effects, and we stopped that. And the PSA over the years has climbed, and around 20, 21, 22, it was stable up to a point, and then it climbed up to about 10. So for 3 years, there was no treatments because of the toxic reaction I had. And then last June, the PSA level climbed to about 37. I went on another round of Zoladex, and this time round, I managed 3 months of it again, and all toxic again. It was just hell. It was horrible.
Toxic?
I physically, I couldn't walk. It was terrible. Mental, spiritual hallucinations, constantly weep. It was poisonous. So I couldn't sleep. I'm still working. I've got a physical job. I clean carpet, and so it's pretty physical, and I could barely function. But every time going off the Zoladex, the body kind of recovers, and going on the treatment it takes from you. It does. Last year I went back on Zoladex because the PSA was at 65. So it's just running rife now, and the prescribed medicine is the Zoladex. I managed 2 weeks of darolutamide, and after 3 months I stopped. So end of June, I stopped all treatment again. I don't think I want to go back on it again. So I'm done. The oncologist is, I've spoken to about.
Doctor, I'm no doctor, but maybe you could sort of take consideration of the trials that Katie's talking about, of going on to actinium or whatever trials, if that's possible, to avoid the use of ADT, hormone treatment. Is that possible, Katie? With those sort of effects, are those trials that are nuclear medicine based appropriate, do you think?
I think so, but I think it would depend on whether there is definite sort of positivity on metastases. So whether your scans are showing a sort of high degree of metastatic burden. And I guess it depends on where those metastases are. But I think, something like targeted radiotherapy would definitely be an option. But usually to get on these kinds of trials, because they are primarily for, unfortunately, often they're for end-stage disease. And so it's kind of like a last attempt at treating men when, your first, second, third, fourth line therapies have failed. So at the moment, people, clinicians, radiologists are trying to push to have these kinds of trials open up to people who have failed, just one therapy or 2 therapies. But still, we're sort of in the climate where clinicians and oncologists are more likely to take you off a drug that's not currently working, put you on another drug, and then see if that works. And then when that stops, put you on another drug. And then when that stops, you go into these clinical trials. So I think there is a space opened up for certain patients or men who do have a really high degree of metastatic burden, particularly in bone. That kind of automatically qualifies for you, these kind of trials. But, you know, there is exclusion criteria based on some of the previous treatments that you might have had, because they can interfere with the radiotherapy. And so, you know, I think if something really is not working and you are sort of going back on the therapy and back on the same therapy and back on the same therapy, I would definitely talk to your GP or clinician or oncologist about trying something else, because there are so many other alternative therapies out there. Rather than having you go back on the same thing again and again and again and again and again, if it's having such nasty side effects and it's just not doing anything.
So, well, Rhino, have you had a gene test done of germline and somatic?
I don't know. I don't think so. They've done some DNA stuff, but that's it.
So if your DNA has some of the genes such as BRCA1, BRCA2, and others, then perhaps you have a predisposition to getting prostate cancer. And there is a class of drug called PARP inhibitors, which are specifically designed to also, I can't recall you mentioning if you had any gallium scans or anything like that, because if you can identify that you've got just a few lesions, maybe up to 5, irrespective of whether they're in bone or lymph nodes or what have you, then you may be able to consider stereotactic radiation, which is radiation coming from multiple directions to a single identified focal point, which then Alan Barley refers to it as spot welding, to burn those particular lesions out and wipe them out. Of course, if the lesions are too many, then it becomes a relatively impossible task, in which case broader radiation is required.
Yeah, look, my spine, there's 2 massive lesions on the spine. So there's, weeks ago, there's a doctor, Katie might know him, a Dr. Knox, Westmead Hospital. He's also some sort of researcher, and they kind of offered radiation therapy. But the treatment has so worn me down. I'm done. I'm finished. I've not, you know, pulling the pin on the treatment end of June. I still haven't recovered. You know, anxiety issues and, you know, stuff that the drugs bring. I've looked at it as the stuff is poisoning me, and I'm done with it. But whatever's out there, I'm finished. I don't want to go through what I've gone through last year and recently. So, you know, Peter, as well, when I watched one of the YouTube things with Peter mentioned he was on something like 21 tablets, darolutamides and whatever it was. And I'm like, 21 tablets, how do you use your body manage this stuff? Here I go on a monthly Zoladex, and I become a zombie. I fall apart. I can't function. It's terrible. So it's obviously my body's different. You know, there obviously are folk out there that deal with the same issues I deal with. But, you know, you're looking at it, you know, well, you guys, 7 years, 10 years. I don't know how your body copes with it. I'm not going to put myself through mentally, physically and spiritually again, because I just do not recover well from the treatment. You know, it's another 3, 4, 5 months before my headspace and my body comes right. And, you know, then within 6 months, the PSA is going to rocket. You know, it's probably up to about 10 again. back on the Zoladex. I mean, why is the oncologist doing this? These are smart folk. They aren't idiots. They're part of this massive Sydney West cancer network with researchers and oncologists and Zoladex. It's like I'm like an individual that's bumping his head against the wall all the time. Going on the treatment, going through all this.
One of my friends, he had his wife pass away due to breast cancer, and that journey for her with chemo was very, very difficult. And as a result, he swore not to undertake the sort of after he was found to have prostate cancer. So he didn't want to go on ADT, he didn't want to go on chemo, he didn't want to do any of those sort of things. I managed to convince him to try stereotactic radiation. And so he did go and have a PET scan, and they identified, I think 3 or 4 lesions, and he did have stereotactic radiation, as I mentioned before. He's now about 3 years along, and he's traveling Europe, visiting just recently did a car tour around Europe with them, and he's living life to the full. He had no stereotactic radiation, has virtually no side effects. It is not painful. It is a relatively simple and straightforward process to have it done. I would urge you to at least have that discussion with your radiologist. With PARP inhibitors, I'm not sure whether there are any side effects. I've not experienced PARP inhibitors myself, so I don't know. But certainly, this friend of mine, John Dubois, he's living life to the full at the moment. I urge you to consider that.
Jim here.
Jim?
Rhino, it's perfectly acceptable to yourself and to your family and everyone else that you can decide to pull the plug, especially if it really interferes with your quality of life. The radiation and PARP inhibitors are something that your doctor might think about if you talk to him. But I was just going to add one unusual one. The primary hormone therapy that you have, yours is Zoladex. Almost all of its effects are because it removes testosterone from your body, the male hormone testosterone. And the result of doing that is what causes almost all the side effects. I'm saying almost all because I used to say, along with saying I'm not a doctor, talk to your doctor about this, I used to say all those effects are caused by the removal of the testosterone and related sex hormones. But then a chappie we had said that he was allergic to, it would have been probably Zoladex, because that's most often given as a first shot. And I might speak about that in a minute. But he changed after a reading of some research over in Italy, I think it was, changed to a different ADT, that's primary hormone therapy, and his problems were resolved. If your doctor was thinking about doing that, then you'd probably get a dose of triptorelin that you heard about earlier as a primary hormone therapy. And the beauty of that is it only has a half-life of 1 month, so that you're on full dose for 28 days, actually. And then by the time another 28 days are gone, half of it's out your body, and then another 28 days, 3/4 of it's out your body, and so on. So you'd want to try something with a different brand that has a 1 month dose. The beauty of triptorelin, the really good thing about triptorelin, this is just a personal thing. I had triptorelin a few days ago, and it's like a mosquito bite compared to Zoladex. Now, the reason Zoladex is mostly given in Australia particularly is that all of these hormone therapies require mixing a couple of things. You know, it's like you know, mixing the parts for your glues or things like that. You know, the 2-part. I've forgotten the name of them, but
Araldite.
Araldite, yes, Araldite, yes. It's like mixing Araldite, but with solid, and it very much depends upon the skill of the people who are mixing it, and they can be easily messed up and so on. But Zoladex, they mix it up in the factory, and then when it's mixed up, they take a little drop of it, of the mixture, and they put it in that great big horse needle that you had stuck in your stomach. And it's very painful. It's also not as effective long term as triptorelin. But if you're going to talk about to your doctor about this, one thing you might suggest, now it's obviously not very common, but people do become allergic to some of the carriers that go along with the active ingredient, and Zoladex might be especially. I'm getting away from. No, I'm not a doctor here, but seeing it's already pre-mixed, they might have to have more stuff mixed in. This one that lasts for months and months and months while it's waiting, than the other ones they mix and put in a few minutes. That's my 2 obs worth.
Look, I've not been offered any of the stuff that you guys have been speaking about the last couple of months that I've been, you know, watching the videos and whatever. But
whereabouts are you?
I'm in Sydney. And you know, the cancer network that I'm in is it's the Westmead, the South or Western Sydney Cancer Network. And yeah, as I say, the Zoladex is what I'm bumping my head with, and that's it. But it's let's say the frustrations that I've had with you know, the oncologists. You know, don't I qualify for these other drugs? Because if I don't, I am a pretty difficult patient. I've become a difficult patient for the system. You know, questions asked, and
Tony Maxwell.
Yeah.
Who's the professor at Westmead?
Sorry?
Who's the professor at Westmead?
What, for radiology?
The chappie that
Sandra Turner.
Hey?
I think she means the oncologist.
Yeah,
the radiation oncologist.
No,
The medical oncologist.
medical oncologist.
Howard Gurney.
Howard Gurney. So a man who's given us a lot of advice through a number of members over the years is Howard Gurney. And he goes at Westmead, and perhaps your GP might be able to refer you to Howard, and then you can ask him whether there are other treatments that he might have suggested or something like that.
I mean, now if he's the head of the department, his minions are the ones I'm dealing with. You know, so it's pointless. You know, I've got a bit of a problem with the establishment right now, and you know, many times I've said to my oncologist that I'm not the enemy, and you mustn't make you know,
so
enemy of yourself. It's just I've reached a stage where I've been so frustrated, and I've had it. You know, I've had it dealing with the GPs, and it all stemmed from that 3-year calamity that we went through with the COVID boogeyman. So for 3 years, I had nothing done because it was a pain and issues dealing with the system. So for 3 years, you know, I lived with no drugs. I was constantly nauseous, and then just dealing with, you know, the system. It just became so bureaucratic. And it obviously leaves, you know, takes its toll on an individual. And unfortunately, I've been one of those.
Okay. So just explain to you that it's not sort of necessarily a hierarchical system. These specialists are more like cottage industries. They all have their own specialty, and they deal with that, and they don't necessarily talk to each other very often. If you did decide you wanted to talk, I mean, it would be a consultation, and you'd obviously then see whether he was matching up with all the other guys, or whether he had another take on it.
It does come down to getting reluctant to change from their oncologist because they think they might insult him or hurt his feelings or something. But bugger that, it's your and you have a choice as to how you want to proceed. And I, for one, had a urologist who did my surgery, and he was showing me a printout of the biopsy, and I said to him, "What's that black dot there?" Outside of the printout of the section of the biopsy, and because all the bad stuff was there was this spot of black on the one side, and I said to him, "What's that bit?" And he said, "That's just an ink smudge. Don't worry about it." So my confidence, my urologist, went through the floor at that point, and I went and got another one. He turned out to be absolutely fantastic. So I strongly urge you as well to go and seek an alternative opinion. But if you go to a surgeon, you'll get a recommendation of surgery. If you go to a radiologist, you'll get a recommendation because they have an overarching perspective of stuff. Just a sec, Tony. And I would also urge you to write down the names of these things that we've mentioned, like stereotactic radiation, like triptorelin, like PARP inhibitors, and go to him and say, "What about this? What about this? What about this?" Because ultimately, you have to take the lead.
Well, the system doesn't like us.
It's your life. You have to take the lead.
You know, when I mentioned your group to the oncologist, and they might watch this someday, and they frowned upon forums like this. So
many of the doctors do, because we're not doctors. We're a bunch of amateurs, and they're worried that you'll get poor advice and follow it. So that's why we often say we're not doctors. Ask your doctor about it. We're just giving you our experience of what's worked for us. That's all. So it's not uncommon. As a matter of fact, I often tell people, not here in public forums, but when I'm talking, I do PCFA man-to-man consultations, and I very often tell them, don't say it was a PCFA group that you got this from. Just to if you have to tell a fib, say you read about it on the internet. Yeah, sorry.
I'm just conflicted. I'm conflicted in dealing with these people. And look at the terms I'm using. These people.
Yes.
I've separated myself from the system, and it's good maybe that I've come on board now and I've shared with blokes that we're on this same journey in a sense, and yeah, I've gone down a different kind of path. It is frustrating. I'd made some decisions the last couple of weeks as well, and when I saw the radiologist, I thought I had something in my jaw, so I went for a bone scan, and there wasn't a tumor in my jaw, and there's all these little issues, these little foxes going on in my body. Anyway, he then backtracked. I mean, he was saying that no radiation at this stage, and then he backtracked after the consultation and said, if you need it and there's some pain in your spine, we'll do some radiation on your spine. It's just frustrating. So I made some decisions and I'm not going to deal with these people anymore. I'm done. Check my PSA every month and let's see where it goes. When it gets to whatever, how's my body going to fall apart? I've managed for 5 years. What is 65? Is that I kind of question, is that bad? Am I in trouble? I've been in trouble from day one. So, and going through this mental anguish and frustrations it's not good. It's not good. So,
Tony here, can I get a word in edgeways here for a couple of minutes?
Can you go ahead?
Tony Maxwell? I picked up all the detail with Reno, but I'm in Sydney. I've been on hormone treatment now for 21 years, which is Leukerin and enzalutamide more recently. I'm still on them. I get horrible fatigue, but I can manage. More recently, my PSA started going up again, and they did some more scans and found that there was one lesion in the right pelvic lymph node. It's not in my spine, it's not elsewhere in the body, as far as we can tell. And so I had about 4 or 5 sessions of stereotactic radiation at Westmead Hospital with Amy Hayden, the radiation oncologist there. And my PSA has dropped down to virtually 0, and it's sitting on 0 now. So, you've got a situation, I think, where you've got stuff in your spine, you've got wherever. Stereotactic radiation worked well for me, and I've heard that it works well, but there's an upper limit on how many lesions they can treat it with and where they are. So if you've explored all those options, I would suggest, maybe your decision is a reasonable one. But if you haven't, can I suggest you do that?
Yeah, I'll not say anything about Amy Hayden. So I just don't want to compromise myself. I'm still alive, and these are people that I need to still deal with maybe down the line. But unfortunately, I'd rather not say anything about that individual. Anyway, it's just frustrating. It's
well, also, I don't know if you're aware of websites, certainly in Victoria, or I guess in New South Wales, that list what trials are available in various disciplines. And if you use the Google Meister, if you just Google prostate cancer trials, New South Wales or Australia or something like that, then it should come up with a list of what's available, and it should identify what the qualifying requirements are in order for you to participate. And that's another avenue for you to pursue. But I'm with Tony. I think certainly each of us has a different response to the medication we're on, but explore the alternatives, and it's up to you to do that.
Just one extra thing. I'm a member of the Westmead support group in Sydney for PCFA, and we've got a guy there who basically has sort of laughed at prostate cancer for many, many years now. His PSA is all over the place, up in the hundreds, and he basically just moves along and does what he does. So it might even be worthwhile you talking to somebody like that. Get some sort of a feel for, a person who's adopted an alternative approach to this, and be able to sort of compare notes with somebody that might be in a similar situation to yourself.
Anyway, probably Doug.
Yes. Is Reno, have you sought psychological support from professionals? And just on Tony's comment about
these people are worse than the oncologists, psychologists and psychiatrists and the rest. I've had my run-ins with the whole gambit of the whole, and that's why I say the whole Western Sydney Cancer Network is like an incestuous thing. If I want to see another specialist, they all take my file. They take my file in their teamwork, and they figure out that this guy's a problem guy. I'm just, as I say, it's just frustrating. I've looked at all these avenues. I've been through the whole gambit. The only drugs I'm on are oxycodones. I'm up to about 100 milligrams a day for the bone cancer pain. But regarding antidepressants, and it's a constant. The antidepressants do not work with me. It puts a block in my system. It's a big mental thing as well. They're horrible stuff. Some folk can take the stuff and I can't.
What other supports do you have? Family support, and as Tony said, about someone who's in a support group, you'll probably find someone who has similarly lived this experience that may be able to talk to you on that personal level. Most of the people on this group here have gathered their information on the personal experience from friends and those in this group. And I've found that, being part of a group has certainly helped me. And there's a gentleman in our group who is going on a trial just this week. He does have metastases in his bones, one in his skull and some down the spine. Yes, he has had problems most recently with pain. The node's been pressing on his kidney. He's recently got stents in his kidney, and he's looking he's putting on the fight. He is 65, but he was probably diagnosed 12 years ago. So yeah, I'm like everyone else. I know you're at the end of your tether, but life is more precious, I think, for your family if you can jump over that hurdle.
Look, it's become a lonely journey. I've sort of ostracized the family. There was a church group as well at one stage, and it's just, as I say, it's just become pretty frustrating. And hence I'm on this forum now. Maybe it's something that's meant to be. I've reached out, I've said my say. So I'm at a stage where it's there's just distrust, me toward the system as well. I can imagine me going to the oncologist. A couple of weeks. I'm back there with my latest blood test or PSA test, and I've got this list. What about this? What about that? And they're gonna, because in the past I've questioned certain things, and I've been told I was told off about some issues.
Does anyone else accompany you to the oncologist appointment?
No. Look, this is my journey. This is my journey. My family's
right now. It's not a journey that one should go alone. I have my wife. I have, and outside that, I have the strong group of men in the support group that we exercise on Monday and Wednesday, and after that we have coffee. It's being able to share the difficulty of what we're dealing with that in some ways lightens the burden. My friend, he's not giving up. And I, also have had, I had prostate cancer, but last year I had non-Hodgkin's lymphoma and went through treatment for that. Life goes on. I'm into living the best life I can. I don't want to give up.
Look, I'm giving up on the system. I'm not giving up. I'm still functioning. I'm alive. I interact with folk. I'm working as best I can with this, messed up body. But the treatments have just, everything has culminated in what you see now. This is my reaction.
So
abrasive and frustrated, and it's just one of those things.
So we are at 12 o'clock now. So perhaps we can just, if anybody else quickly wants to share their situation and ask for any opinions from the group. Otherwise, I think in fairness to all, to Katie, just a sec, Doug, in fairness to all and to Katie, we should move on to closing. But Doug, you wanted to say something?
Yeah, very quick. Diagnosed 2012, surgery 2012. Original biopsy was 6. Post-surgery Gleason 9. Surgeon said my gut churned when I saw that. But PSA was never 0. Went up. I had PSMA scans 2015. PSA, even though they were low, they were rapidly rising. Had chemo. It was in left lateral internal iliac node. Couldn't arc stereotactic, too close to the ureter. So I had chemotherapy and on the hormone, which was a stampede. PSA finally came down to less than 0.008 in April 2016. And I've been in that situation ever since, on Zoladex, as the oncologist said, for the rest of life until till this fails. I've never had a holiday, therefore, so far I've been lucky. No, sorry, fortunate. Yeah, that's it in a nutshell.
Well,
thank you.
Well, you've got quite a ways to go yet with various alternatives. So, as I said, I was on first generation hormone treatment, and likewise Tony, and I've been got 5 years out of enzalutamide, and Alan Barley, I think, has got something like years out of what is it, Jim?
He's
one of the other.
He's on Zytiga. He's had it for about 8 or 9 years.
Yeah. Zytiga, and then there are all of these new things that Katie is working on, and the say it again, part of it is the nuclear medicine, and so on. So hang in there, mate. Anybody else who wants to have a quick word about something? Tony? Mute. You're muted. Oh, you're waving goodbye, are you? Tony Maxwell. Can't hear you. You're going.
I'm just waving goodbye.
Goodbye.
Thanks to everybody.
Farewell.
Goodbye, everyone.
Okay. Thanks a lot again, Katie.
Thanks, Katie.
Really appreciate your participation. Hope you got something out of it yourself.
I did, and I actually just really enjoyed listening to the discussion that you've all just had, because obviously, as researchers, one of the sort of, I guess, flip sides of us being stuck in the lab all day is that we don't get out and hear the stories from men who actually have prostate cancer and what they're going through, and how difficult and frustrating it can be. And it's really good for, I think, us to also get up close and personal with that kind of journey, just to keep things, I guess, our goals in focus, and why we're doing all this kinds of research in the first place. And so what I've actually been talking, I think I've mentioned it to Tony before in the past, and I've mentioned it to another person that I have, that I work closely with on prostate cancer at Peter Mac. She's another consumer. I'm sort of looking to try and host a bit of a seminar session at Peter Mac that brings together people with prostate cancer, but also researchers and clinicians, so we can all have a big group chat and everybody can sort of understand what is happening in the space of the individual, pockets that all go towards improving, therapies and outcomes for men with prostate cancer. But I think it's so important for us to hear the perspective from the people that are going through it. It's really great for us. So thank you for letting me stay on and having your conversations. And I do want to say, just on the PARP inhibitor front, that there's a lot of trials that are going to be coming up over the next 12 months that are sort of focused on PARP inhibitors. So I would recommend keeping on those trials.gov websites, because they list all of the trials that are coming up in the prostate cancer space. And you can search by prostate cancer, you can search by metastatic prostate cancer, and it will narrow it down. You can search by your state, and it tells you where these trials are, whether they're recruiting, whether they're active, and whether you meet the requirements. And so they're just some searches that you can do at home, online, some Googling, because there is going to be a lot of work coming up in the PARP inhibitor space that I'm sure many of you can probably get on board.
Terrific.
Okay.
But yep, thank you for having me.
Whilst Jim is the chief, but he's disappeared, I'll just, oh, he's back. if I'm sure that you would have an open invitation to participate, and indeed your colleagues participate in these sessions as you wish and as you see fit. Because I think, and I'm sure everybody here will support me, that it is really important for the people at the right at the front line to understand what the medications do to us, how it affects our well-being and what have you, and to personalise the fantastic efforts that you're putting into your great work.
Yeah.
So we do hope to see you again in the future, and certainly if it transpires that you do make some significant discoveries, we'd love to hear about them from you.
Yeah, of course, absolutely.
And on that note, farewell, goodbye, adieu, adieu, adieu. Thank you all for your participation.
Thanks, everybody.
It's been